Good morning, everyone. Sue, I'll turn it to you to start the session.
Yeah, welcome everyone to this first event in our new expert panel series from Health Canada and CanCOVID. My name is Dr. Sue Horton from the University of Waterloo, and I will be one of the two moderators today. Before we get started, I've been asked to share some instructions as we're providing simultaneous translation into French. Bonjour tout le monde et bienvenue au tout premier événement de notre nouvelle série de groupes d'experts de Santé Canada et de CanCOVID. Je suis la docteure Sue Horton de l'Université de Waterloo et je serai l'une de vos deux modératrices aujourd'hui. Avant de commencer, on m'a demandé de partager quelques informations sur le déroulement de l'événement, car nous en assurons la traduction simultanée en français. Today's presentation will be in English, but we will have simultaneous translation available in French. La présentation d'aujourd'hui se fera en anglais, mais nous présentons une traduction simultanée en français. Pour nos participants francophones, veuillez vous rendre au bas de votre écran Zoom où vous verrez l'icône d'un globe. Cliquez sur le globe et choisissez French si vous voulez écouter la présentation d'aujourd'hui en français. Et vous pouvez également poser vos questions en anglais ou en français. Please go ahead and select your language preference now. C'est le moment de sélectionner votre préférence linguistique maintenant. As you are aware, we are fortunate to have participants joining us from all across the world for today's session. I am in the Caribbean and there is a huge thunderstorm and I have lost power, so I'm sorry you cannot see me. I'm on the phone. Given the multi-globe participation, it is challenging to acknowledge one specific Indigenous territory today in the form of a land acknowledgement. As such, in the spirit of our commitment to reconciliation and continuing to strengthen the relationships and understanding between non-Indigenous and Indigenous peoples, we would ask each of you to take a moment to honor and reflect upon the traditional territory or land upon which you currently live. And now I'm passing this to Christine Leckie, who is the other moderator.
Thank you so much, Sue, and good morning, good afternoon, everyone, depending on where you're joining us from today. I'm Christine Leckie, and I'm the Acting Executive Director with the Medical Devices Directorate of Health Canada, and myself and my team are responsible for conducting the scientific evaluations of COVID-19 tests and authorizing them at a federal level in Canada. As Sue indicated, we wanted to briefly provide an overview of the structure for today's session, introduce the themes we have asked our panelists to address, and lastly, set the tone and expectations. Avant de commencer, nous voulions donner un bref aperçu de la structure de la séance aujourd'hui, présenter les thèmes que nous avons demandé à notre panéliste d'aborder, et enfin, donner le ton et les attentes. We provided our panelists with a list of questions that fall within 4 themes and asked them to briefly summarize their perspectives in a period of 5 to 6 minutes. The themes are as follows: lessons learned for COVID-19 rapid testing strategies, the gathering and use of data, how to better support the development and innovation of COVID-19 diagnostics and related technologies, and best practices for effective communications and messaging. Once the panelists have provided their perspectives, we will then commence the Q&A portion of the session, where you will have an opportunity to ask questions. In the interest of time, some of the questions may be combined or summarized. And what I will do is select the questions and we will post them into the chat function for everyone to see for reference. Now, I did want to now start by introducing our amazing group of panelists. But before I did that, I did just want to take a minute to talk about what this session is and also what this session is not. So first, this session is a respectful and safe space to hear the perspectives of world-leading experts based on their respective lived experiences related to COVID-19 lessons learned to date, available evidence, and future considerations related to rapid testing and screening. It is also an invaluable way for all of us to take some dedicated time at this point in the global COVID-19 pandemic to listen, to share, to reflect, and to learn from one another in the spirit of collaboration and continuous improvement at a global level. What this session is, though, is not a debate, nor it is a place to provide policy recommendations. So without further ado, I'm very happy to start with introducing our very prestigious panel of experts. Dr. Mark Perkins trained in medicine and infectious diseases and has been working for the past 30 years on diagnostic testing for poverty-related infectious diseases. He co-founded FIND in 2003, where he served as chief scientist. He currently works in the World Health Organization Health Emergencies Program as the team lead for laboratories. We also are grateful to have Dr. Michael Mina with us today, who is the Chief Science Officer of EMED. Prior to EMED, Dr. Mina was a professor of epidemiology, immunology, and infectious diseases at the Harvard T.H. Chan School of Public Health, a professor of the Department of Pathology at Harvard Medical School, and Associate Medical Director of Molecular Virology at Brigham and Women's Hospital. And we also have with us Dr. Lisa Barrett, who is a clinician investigator and assistant professor in the Division of Infectious Diseases, Department of Medicine, Department of Microbiology and Immunology, and also Department of Pathology at Dalhousie University. She is currently the principal investigator of the SAIL laboratory that studies immune responses in chronic and persistent viral infections. And so if your connections are working all right, I'll turn to you to introduce the remainder of our panelists.
Yes, it's my great pleasure first to introduce Dr. Mel Krajden, who's the Medical Director of the BC or British Columbia Centre for Disease Control Public Health Laboratory, and also a Professor of Pathology and Laboratory Medicine at the University of British Columbia. He's currently a member of the Federal COVID Immunity Task Force Leadership Group, among many other high-profile positions. Next, I'd like to introduce Dr. Cédric Yansouni, who is Associate Professor of Infectious Disease and Medical Microbiology at McGill University Health Centre in Montreal. He also serves as an Associate Director of the J.D. McLean Centre for Tropical Disease. His research focuses on informing policy on diagnostics, with special emphasis on diagnostic tools for infections in low resource and remote settings, including remote Indigenous communities in Canada. And our third panelist, our sixth panelist, is Macia Palacini, who has been served 2 terms as the chief of the Cloyne First Nation, and she's also worked in the government cabinet office in the Yukon, and currently she is leading her strategy work with GSD Strategies, her company, in providing services for Canada's Indigenous government and northern communities. I will also introduce Carrie Johnston, who is not presenting in the first stage, but who will be assisting in the panel discussion and responding to questions. Carrie Johnston has lived in the Yukon for the past 15 years. During the COVID-19 pandemic, she has focused on COVID-19 communications, research, capacity building, and logistics. She works concurrently for Yukon First Nations COVID response as the communications lead, and for Champagne and Aishihik First Nations as COVID coordinator. And I think that's the end of the introduction. And at this point, I would like to invite Dr. Mark Perkins to make his remarks.
First, I'd like to just verify that you can hear me.
Yes, we can hear you.
Super. Thank you very much. It's nice to speak to this educated audience about a topic that is of close interest to many of us. I'm assuming that this is a seasoned audience that has been through a number of such conversations and presentations, and I won't review in the start of this discussion the epidemiology of COVID globally over the last 3 years, and the different genotypic phases of presence of local virus across countries, depending on geography and management. But suffice it to say that COVID-19 has the outbreak has cast a spotlight on the failures and successes of a variety of response regimens for outbreak pathogens. We have been preaching the verb of preparedness, and yet when there's a new outbreak, we find ourselves often woefully unprepared. The specific responses or parameters of responses to COVID has varied markedly from country to country, and a one-size-fits-all approach to diagnostics or to treatment has not really found relevance in the global landscape. So we have a setting in which diagnosis is relatively straightforward, treatment is highly complex, and budgets for health systems are severely restricted. So we have a lot of decisions to make on a very short shoestring. Rapid diagnostic testing or diagnostic testing at all can be critical in the management of infectious diseases, but the impact of the diagnostic process of knowing what the diagnosis is depends on the morbidity and mortality of disease, the capacity to detect cases early, and the emergence of the availability of therapeutics, which have until recently not really been available at all. With the vertical programs in TB and HIV and malaria to look at, there are a number of successes to be claimed in the public sector about how we can set up diagnostic screening programs that meet the needs and have local health impacts that are significant. For COVID, it's been much more complicated because case fatality rates are relatively low. The number of people who will not have a severe bad outcome who are infected is high. So even the clinical specificity is relatively limited. And we have, on the top of that, a relatively active set of thoughts around how we would use diagnostics, either molecular or lateral flow immunoassays, to detect the infectious pathogen and treat or let that diagnostic pathway direct the movements of people's into sports stadiums, airplanes, other settings. So it's we have a world-changing event, COVID-19, that is a relatively low pathogen, a low severity pathogen in general. Not just if you have a family member who, of course, died of COVID, then you understand that locally and individually pathogenicity is very high, but compared to other outbreak pathogens that could have been circulating, it's been relatively low. We have a global opportunity and requirement to have a discussion about what do we do, how do we make a cost-effective response that makes sense to lower middle-income countries, and tailor it in such a way that countries who are island, tropical nation states in the South Pacific, for example, for whom cuts in travel as a destination to their countries because of COVID is a life-changing event for their populace. And on the other hand, we have countries that have much less, much greater, much lower requirements for stringency. So we have quite a job, and it depends on what the answers to these questions depend on the population involved. And I'll be very interested to talk to you about specifically the Canadian situation. Thanks very much.
Thank you so much, Dr. Perkins. Very interesting to hear your thoughts, especially from a global perspective. So we'll now turn to Dr. Michael Mina.
Thank you very much. So I think one of the first things that we really learned in this pandemic as it pertains to testing is that we have been given a new opportunity, I think, to really reapproach how we view diagnostics and how we view everything from PCR to blood testing to rapid testing. When the pandemic first hit, and to an extent, even up through till today, there's been this immense focus on the very highest sensitivity tests as being the approach to go with. In the United States, it took immense amount of effort to start focusing the US on testing that wasn't performed in a lab. And this was really the case across the world, and including Canada. And what we found is that there's this whole missing piece when it comes to testing. Traditionally, testing has been performed in hospitals. The idea of not having enough test capacity is generally not something most folks think about, even up to and including public health practitioners. The data is just usually there for epidemiology work to be done. The physician never has to wonder, can I actually hit this button to order a test for my patient? And at the same time, that physician is usually seeing a patient and is able to say to the patient, look, you might or might not be infected, but you're clearly symptomatic, and I would support you going home and isolating. We'll get your result back to you tomorrow. So that's a very medical idea of how testing should be performed. But what happened in this pandemic was in order to focus and prioritize very high sensitivity medical testing, we made a massive sacrifice. And that sacrifice was in how fast the turnaround time was for the test result and what sort of access people had. And I think something that has, outside of very small circles of public health practitioners who normally work on outbreaks like Ebola, there hasn't been a major focus really ever on different metrics that qualify a test to be an appropriate type of test for a pandemic. And in this case, what we've shown in numerous publications now, and I think the world has started to kind of informally just recognize, is that speed is 100% of the essence. Speed is essential. Access is essential. In the United States, we had an FDA, for example, that would have at certain times in this pandemic preferred, and not just would have, did prefer a laboratory PCR test that took 10 days to return over a rapid test that took 10 minutes to return. Obviously, I think now that we've come far enough over the last 2+ years to realize how ridiculous that is. A COVID test that gives you a result back in 10 days has never made sense. And now I think it's apparent that it doesn't make sense. And if you can get a 90% of the power of a test out of one that gives you results in 20 minutes versus days, that becomes massively important if your goal is public health testing. And this is I think what the pandemic has really shown, and something that I've put a lot of energy into thinking about, is what is a public health test? What is a medical test? And in particular, how can we think about this from a regulatory perspective? Because this is really where everything got pretty botched, was how does the regulatory structure that most countries have in place, how does it fit the needs of a pandemic when pandemic needs are just not what a physician would normally be looking for? So there's a few simple definitions. For example, if the primary objective of testing is for the benefit of the people around the test user, then I would define that as a public health test, meaning that if you're going to test, not for your own health per se, but to know if you need to be screened out of entering into a location because you might infect other people, or if the consequence of that test is something that would never be prescribed through a medical pathway like isolation. Isolation, no doctor in the world should prescribe somebody isolation. It's not in that patient's best interest, but it's in the best interest of the people around that person. So that is a public health use of a test. And different metrics are required to really recognize that that test is being used, that's the appropriate test that's being used. For entrance screening, a test that's 24 hours delayed is not an effective test in any way, shape, or form, not even close to even a lower sensitivity rapid test. And a medical test, obviously, I think we're all familiar, is a test that where the primary beneficiary of that test is the user of the test. And it might be to get treatment. It might be to have a physician help them through their healing process or their hospitalization stay, example. And so these types of this type of thinking just doesn't exist in our regulatory space almost at all, especially in the United States. It doesn't exist, and we've had to make some serious compromises. And in the process of trying to fit medical testing into a public health landscape, we've found, for example, just a major dilution of what it means to have prescribed testing. For example, the purpose of a prescription was really diluted down because all of a sudden we just had millions of prescriptions going out for, lining up college students to enter school, all types of things. That is not what medical prescriptions are really designed for. So I think that these two, to me, this has been one of the major foci, and I hope that regulatory agencies, as we move forward, actually start to carve out specific pathways that are really directed towards regulating tests that aren't for medical purposes, but that are for public health purposes. And if this COVID pandemic can get us to that point, I think it would be a massive success from a regulatory perspective. And just to mention, we are already seeing the exact same Groundhog Day problems play out with monkeypox. We have very slow, very limited access to laboratory PCR, and then we have potential for massive access to very easy, simple to use tests that people could use on their own at home. And those probably will take, in the United States anyway, a year plus before they are available, even though they will be the same tests existing today as what will ultimately be authorized. And so I think that we have an opportunity to change that script, but it needs to, I think we really need a concerted effort to make it happen.
Thank you so much for sharing your views, Dr. Michael Mina. I really appreciate it. And then we'll turn next to Dr. Lisa Barrett.
Good morning. And Christine, I'll just make sure that you can hear me if I can get a yes before I start.
Yes, we can hear you and we can see you very clearly.
Excellent. That's great. Good morning, everyone, and thanks for inviting me to be here. And fortunately, just after Dr. Mina, I'm going to build a little bit on some of the things that he was saying and provide some context in terms of a bit of a case study of what has happened in Nova Scotia, which is where I am based, as we go into a discussion. And two things that I'd like to highlight in my comments would be very specifically, one, the difference between how we think about testing in terms of diagnostics in a very traditional sense versus as a tool of engagement or as a personal and public health tool. And number two, where we might be able to go forward from here. So as I said, I'm based in Nova Scotia, and during the pandemic, very early on, we started to think about the use of diagnostic tests, as they were called, but particularly rapid tests and almost exclusively rapid antigen tests as a way that in a province of about 1 million people where we have limited lab resources, how we could actually mitigate the impact of infection spread in addition to our other public health policy and protections, how we could limit the spread of virus in our community. And one of the things that was very quickly recognized was that PCR could not be one of our core ways of doing that if we wanted to use a high level of testing to mitigate spread. So timeliness, number of tests, and minimally symptomatic people, as well as those without clear symptoms, as we were early in the pandemic and knew very little other than the fact that this was a very spreadable virus, even in the asymptomatic phase. And because of that, we took an approach of using rapid antigen tests that were not just being used as a pure medical diagnostic, but over the course of a year and a half, we moved from the use of rapid antigen tests with PCR confirmation after, but then without PCR confirmation, to test people who had either mild or no symptoms. And we did that not with medical experts or medical practitioners as the people collecting first the nasopharyngeal swab, then the nose, the nares swabs, then the nose throat swabs. We actually moved to a completely and very early model of non-medical experts, people from the general public, from librarians to real estate agents to various other folks from the general community who learned very quickly how to collect these swabs and then to do the rapid antigen tests on site at first. And we were seeing up to thousands of people a day in our 1 million population through the courses of waves 2, 3, and most recently 4, who were taking advantage of that testing. And in wave 3, in conjunction with other public health measures, the broad and widespread use of non-medical expert-driven, volunteer-driven testing as part of our culture of pandemic response was effective in bringing our third wave down far more quickly than we had expected. And then we moved very quickly over the course of about 10 to 12 months into a model where we were giving people these rapid antigen tests to take home with them with very easy, simple instructions so that they could use them either in the minimally symptomatic or asymptomatic, no symptom or low symptom phases, both as a tool to be able to know when they had COVID, but also if they were going to be around particularly vulnerable populations, that they could do their own testing. And this included some school-age children populations, as well as workplace programs and the general population, including some focused efforts when we started to reopen around nightclubs and younger folks who would be minimally symptomatic, but maybe in contact with highly vulnerable humans. And there was two things to learn from this. Number one, we started to think about tests, not just as a diagnostic tool. A positive was helpful, a negative, as we used to say, was just for the night or the day. And we learned that people, number one, could do this themselves. Number two, it provided self-determination, and people were very, very frequently commenting on their ability to know their status, which, as Dr. Perkins mentioned in the first part, is a big part of how we've started to socialize and destigmatize and demedicalize testing within the HIV community, to know your status. People were encouraged to do that, and they very quickly culturally became adept and competent at knowing how to interpret a positive and a negative. Very difficult to show that at a population level, but certainly the qualitative data that we are putting together is definitely in favor of the fact that people know how to interpret tests when they're given the choice. So demedicalization, use of a test, not just as a diagnostic for when you're symptomatic, but for mitigating spread when we still know not a lot about the longer term effects of COVID. And we recognize the importance but limitations around our vaccines, as well as other public health measures as they disappear in terms of isolation. So I think two bits: one, the demedicalization, the volunteer-led part, and the ability to engage a population in determining their own health were things that we didn't set out to discover necessarily, but have become very important parts of the response that takes the word test out of the world of the medical expert and puts it into the hands of people as a tool of self-determination. And if there's one thing I think that we need to really look forward to, even beyond COVID, maybe in the respiratory illness world in general, as we start to think about mitigating the impacts on society in many different settings, either developed or developing, is that ability to limit or mitigate the impact of perpetual and seasonal respiratory illness and other illnesses as we go forward, if we have easy and cheap technologies that can help people to do that at an individual level. And so I think the opportunity, one, as Dr. Mina had mentioned, change the way we think about testing from a sole diagnostic in a hospital setting to a tool that can be used by individuals and groups to maintain, develop, and mitigate impact of health, of disease in their populations. And then number two, how do we do that from a regulatory perspective? And is there a separate path or a conversation we need to start having between pure diagnostics and taking things into the community? We've started to do that. I mean, we've had pregnancy tests in the community for years. This is a little different given the impact, but certainly a conversation that we need to continue and expand as we've watched both the impact on a go-forward basis for future pandemics, building cultural response that's self-based for people to have that self-determination, but also for us to be able to have a mitigation strategy if people deem it to be important for their own health. So I'll leave my comments there and would love to answer some questions later if there are any. Thanks for your time.
Thank you so much, Dr. Barrett. And we'll now turn it over to Dr. Mel Krajden.
Thank you. And I'm going to take a different spin from Lisa and Michael Mina. And I'm going to argue, if you're looking at future pandemics and whether you're dealing with a diagnostic or a public health test, what are the underlying issues that one needs to support decision makers, be they clinicians, public health individuals, regulators, or payers? So one of the things is Canadian manufacturing capacity needs to be able to generate products that are used for day-to-day testing, rapid testing. And the purpose of that is to have constantly advancing technologies that can be adapted rapidly to a new threat. The second point is that we need technology-driven rapid evaluation of test utility. And those need to be honest about its strengths and limitations, and that's very helpful for decision makers. The third is that you need streamlined validation of tests that are deployed, which is the term that refers to getting sites to understand how the test performs in their setting. And you need to overcome accreditation requirements for each site to do its own complete validation. You need to simplify that. The fourth item is you need technology-driven, real-world, rapid evaluation, not only of the product's performance, but its impact on public health outcomes or clinical outcomes. A test is only as good as its ability to engage people into appropriate prevention, care, and treatment. A test should always be thought of in terms of what one will do with the result, either at an individual or a population level. What worked early on in the pandemic may not be relevant today and is likely not relevant today. The fifth point is to enable different sample collection approaches: healthcare provider collected, peer collected, self-collected, lab tested, or self-tested. Each of them have pros and cons. The sixth point is to ensure that the process of sample collection and testing is safe for the tester, be that a healthcare provider, peer, or the individual. The seventh point is to develop comprehensive training and quality assurance training components for the entire testing process, and as well as tools that allow you to monitor inventory and test expiry, because you're going to need that from a system-wide perspective. The eighth point is to provide clear guidance on what the person should do if they test positive or negative or invalid or equivocal. So those pieces are just as crucial, and Lisa highlighted that. Self-management versus engagement into prevention, care, and treatment. People need to know what to do. The ninth point is, what do you do with the result? Who do you report it to? Is it valuable to report it? And you need some technology-driven approaches that can be used for day-to-day testing of things like STIs involving stakeholders. And it's using those lessons learned that could be rapidly adapted to a new emerging threat. And the 10th point is to remember that what works in a city may not work in a remote, rural, and indigenous community. So it's really critical to evaluate products and technologies in the context and the variety of multiple real-world settings, including developing nations. Thank you.
Thank you so much, Dr. Krajden. We'll now turn over to Dr. Cédric Yansouni.
Dr. Yansouni, I believe you're on mute.
My apologies. It's only been 3 years that we've been doing this. So I want to thank the organizers for inviting me on such a prestigious and stacked panel. It's a real pleasure for me. I'm going to comment with a lens really looking at the situation in Canada. It's no surprise that I agree with much of what's been said. You know, rapid antigen tests were approved in Canada in mid-2020, but individually packaged rapid antigen tests for self-testing were approved in around December 2021. And in that interval, there was tremendous heterogeneity in the country of how they were used, how much they were used, if they were used at all. I think Dr. Barrett in Nova Scotia has really been a leader of innovation in the country, of how these tests were deployed early on, perhaps related to the capacity of traditional testing. But, you know, I think that the way that tests were used in that interval between the time when they were available and approved for individual self-testing really brings up several issues that sometimes are competing with each other that bear discussion. I think the first, which has been alluded to, has been with respect to self-tests. We have initially focused on narrowly defined diagnostic accuracy, frequently at the expense of the diagnostic indication that would be useful for the test. We all know in the room that rapid antigen tests are less sensitive than nucleic acid amplification tests. But the most sensitive test is really useful for individual patient management. We've known from very early on that rapid antigen tests are pretty good surrogates of whether or not a person is shedding virus that can be cultured. And that is probably the best indicator we have of whether that person is infectious to others. So, defining rapid tests as not as diagnostic tests, as defining what you have, but as defining them by their ability to identify people who are most likely to be contagious is really important. That's probably what their lasting use will be. But as has been mentioned, there hasn't been a dedicated way to approve such tests, neither at the regulatory level nor at the more downstream clinical guideline level. I think so. The first lesson that I would take is, the Medical Devices Evaluation Bureau at Health Canada has been, the front face of this of test approval. But I think we need to recognize that this is a relatively small office that was reinvigorated for COVID. But this is an office that should be empowered going on. We need resources. If you want a regulatory agency to be innovative and provide real-time assessments within a changing landscape, you need resources in that regulatory agency. So I think for me, that's lesson in Canada number one, is that if we want to be nimble, we have to enable that nimbleness. Second, once a diagnostic indication is identified, so let's say I'm going to say rapid tests are useful for identifying people who are most likely to be contagious. The situations in which you would want to know that, what I'll define as use cases, really have changed every few weeks during the pandemic. And so outside the regulatory agency, at the level of clinical guidelines and provincial rollouts, that's been a real challenge, right? Because at first, the more innovative voices, or there were many voices saying in the first wave, well, most transmission is among asymptomatic people, so we should be deploying rapid tests among those asymptomatic people to know if you're contagious to others. That's probably not true anymore, right? So now, maybe the one example of a very pertinent use case would be testing to end isolation. Lots of people have published data on whether 5 days is good or not. I mean, it's not, but using a rapid test to decide that you can end isolation is probably a pretty reasonable thing to do. That's changed frequently. And so I think the second lesson I would say is at the level of provinces and individual constituencies, we have to accept that we need to be very nimble, and that we have to reach a compromise between clear messaging that everyone will understand and messaging that's actually useful at this moment in time. And I think that's been a real challenge, and there's a real disconnect still today in the various policies in different institutions across the country, and certainly in Quebec. The third aspect, I think, that is Canada specific is that the use of rapid tests is, on the one hand, we know that there's laboratory data showing they're very well correlated with the likelihood of shedding culturable virus. That was true for earlier variants, and it's still true for Omicron, BA1 and BA2 at least, and probably for subsequent variants so far. We have modeling data that shows that if you take a test that's less sensitive, but you can apply it, you can reach more people, you will, through frequency and denominator, you'll be able to have an impact on transmission in the population. So that's a modeling exercise. We know that when rapid tests are used perfectly, let's say in Slovakia, when they tested 80% of the population over a 2-week period with rapid tests, lots of people said that was ridiculous because they weren't sensitive enough, but they were able to test enough people to lead to an 80% drop in transmission in the subsequent 2 weeks. So we have some real world data. When they're used perfectly, they actually affect community transmission. Those groups of data have to be balanced with the rather disappointing data from more realistic assessments, where we haven't really been able to show that using rapid tests is cost effective to affect transmission on a population level. And so some people have said, well, you can't show that they're cost effective to curb transmission, thus they're useless. And I think that the problem in Canada, is specifically in a single payer healthcare system, has been that when we make policies at the provincial level, because provinces deliver healthcare, often this cost effectiveness, this population effectiveness is used as the metric to say, oh, we'll roll out diagnostic tests for this indication because we've shown cost effectiveness. And if you can't show that, then we're not going to recommend them. And that's where the problem is, because like Dr. Barrett very elegantly described, is that there's a whole range in between population level effectiveness and family level or community level or even individual self-determination level decisions that are valuable, even if they don't reach a marker of what we would call cost effectiveness by some metric. And so in Canada, the problem has been that we really haven't been able to have a good conversation of balancing equity of providing access to tests for indications that are perhaps more strongly supported by evidence, and accessibility to those who wish to make self-determination decisions, even though that use case may not rise to the level of cost effectiveness. And I think for me, who is involved in advising the Ministry of Health in Quebec on several issues, that's the terrain where we've had the most trouble. And because we're allergic to these sort of discussions in Canada that might look like they're affecting equity. But I think we need to define equity of access. There's a lot more to say, and I'm going to conclude simply by saying that in self-testing or in rapid diagnostic testing, we're frequently contaminated by either or thinking, that is either a rapid test done by me or a laboratory test. And I think that what COVID has shown us is that there is a lot of gray, where there are some situations where a sloppy result with an imperfect test and an imperfect performer of the test might still be really useful and valuable. And that's, I think, where we're going to need to negotiate and figure out for other diseases where we're going next. I'll stop it there.
Thank you so much, Dr. Yansouni. And now we will turn it over to Macia.
Hi, my name is Macia Alatini, and I am a Kluane First Nation member from beautiful Kluane territory in the Yukon. I'm zooming in from the traditional territory of the Kwamandun and the Ta'an-Quechan here in Whitehorse, Yukon. Since early March, mid-March of 2020, I've been working with the 14 Yukon First Nations and the neighboring nations in Northern British Columbia and NWT on a coordinated response. It's really an honor to be on this call because Michael, Mina, follow you on Twitter, and Lisa Barrett, Dr. Barrett, all of your work in Nova Scotia has been so helpful. And we do follow a lot of what is happening with the BC First Nation Health Authority and their work with BC Centre for Disease Control. So very honored to be on this panel. We, as Yukon First Nation, so we have 11 self-governing out of the 14 nations in the Yukon. 11 have self-government agreements. And we have been able to implement rapid antigen tests for general population use and for diagnostic use prior to the Yukon government rolling that out. So working with Public Health Agency of Canada on their Northern Remote Communities initiatives through NML, we have had access to PanBio and the BD Veritor and a couple other rapid antigen tests since October 2021. If you think of Yukon First Nations or any First Nation community, you have a lot of multi-generational households, you have a lot of it's communal. So our communities are small and everybody's related to everybody else, and there's a lot of opportunity for transmission. So seeing the use of rapid antigens and how we could use it for diagnostics was incredibly helpful. We were quick to adopt the throat nose testing methodology that was rolled out in Nova Scotia. So thank you to you guys for ground truthing that. And we found the biggest barrier was a Canada or the provincial relationship between Canada and the territory. And this idea that the territory health knows better than the individuals in their community. So I'm a strong advocate for First Nation autonomous decision-making and flattening that curve so that access to diagnostic testing, whether it is rapid antigens or it is the dried blood spots for STIs, we know that our communities, our First Nation communities, are disproportionately affected by this and every other pandemic that comes along. We've got our first case of monkeypox here in the Yukon as of Friday, and knowing that our communities are going to be disproportionately affected, my next challenge is how do I get testing into the hands of our community members? I think there's a piece of just that willingness to let go of control from a governance perspective and push it to that, is this public health initiative? Is this a public health interest? And can we move this out and trust that people can swab their own noses? Definitely a challenge. I do want to speak to the communication. We found that in order to get trust buildup in community for rapid testing, we had to do a number of different types of communication. So our territorial government did press conferences, and that's great because you were able to cover a lot of information, but they're an hour long and not a lot of people were watching them. So we would take segments of those and package them into a social soundbite, I guess, and put that out on either Instagram, TikTok, and we did interviews with experts, nurses, pediatrics, doctors on YouTube, and package those into sound bites. So getting the trusted sources was a big piece of moving our communities to adopt this and to learn how to do it rather quickly. From us rolling out in October of 2021, the first kind of rapid antigen tests, to adopting in, I think, end of January, beginning of February, the throat and nose swabs before anybody else was doing that in the territory, really speaks to the trust that was built through providing unbiased and unfiltered information that the population trusted. So I think I'll leave it there. Oh, maybe centralized data collection. That was always a barrier for Yukon First Nations. There is data that gets shared between Canada and the territory or province, but that does not get shared with the First Nation governments. And that's been problematic for self-governing nations. And if you can imagine, there's 26 or 29 across Canada. So how are those nations being included in our public healthcare system? Thank you.
Thank you so much, Macia. That was very interesting to hear your perspectives and your experiences. So we are at, I guess, about 4 minutes out from the end of our session. And I think we knew that likely these discussions would take the majority of the session. We did have a few questions that have come in. And what I'm going to try to do, I think, is sort of summarize it into one question and leave it open to anyone in the panel that might want to comment. So I think we all acknowledge that we have a really good COVID testing toolbox now, particularly around rapid antigen tests. But there are a number of questions about, I guess, some of the gaps potentially that might exist. So whether it's saliva or sort of some type of technology that could detect COVID in the air, things like that. So just wondering, perhaps maybe we could open it up to our panelists just to get their thoughts about maybe, knowing that it's not a one size fit all approach, which is what we heard a number of times, and that there are, differences and sort of tolerances, cultural sensitivities to certain types of tests, for example. So maybe open it up to the panelists to speak on technologies or gaps, I guess, that they see within our COVID testing toolbox right now.
This is Mark Perkins. I don't have a direct response to. It is true that the way that diagnostic testing has been applied across different regions has been variable, and certainly the methodologies of introduction and the use of the data from which that was recovered from the testing is all very important and varies by city and I suspect by province in Canada, and certainly varies by country. So it's an area that there's a fair amount of not disagreement, but I would say variability in implementation. The use of rapid tests is specific. The validity and utility of the rapid test and other approaches depends specifically on what you're trying to do. And most rapid tests that even detect a very high levels of it, that can only detect high levels of infection, say 10 to the 7th, 10 to the 10th, 10 to the 11th viruses per mil, viral copies per mil. That's enough in a setting where the virus is frequently being transmitted. And what's hard for communities is to figure out how do we shift our engagement if we need to for detection of highly transmissive individuals who have 3+ positive rapid tests, to a different setting in which it's a phase in the epidemic when the case rates are vastly diluted and there's not very many positives, and you're not sure how to use the data that you could use from the former
Thank you so much, Dr. Perkins. And I think just given the time, we will unfortunately have to wrap up our session. Sue, are you able to deliver our closing remarks based on your connectivity? All right, I think she may be having some issues, so I will jump in. But we, on behalf of Sue, myself, and CanCOVID and Health Canada, we want to thank all of the panelists today for coming to share their views, and all the attendees for taking the time out of your schedules as well to join us today. We do actually have a session following this session that will be private, and it will be restricted to Health Canada as well as key federal partners, and will be an opportunity to build on this session and ask some more questions of our speakers. And if you did miss a portion of today's event, you are encouraged to visit the CanCOVID website early next week, and we will have a recording there posted for those that would like to see that. And for those that did accept to be part of the private session, which is commencing now, we did just want to flag that you should have received an email with the Zoom link to join, as the current session will be ending. So again, merci beaucoup. Thank you so much for all of you. Thanks again. Take care. Bye-bye.